Next is going to be another one of our talented senior fellows, Dr. Jessica Nguyen-Trong, and the title of her presentation is Advanced Imaging.
All right, last case. Thank you for everybody for participating today in the conference. And with that, we'll get started. I have no disclosures. So the case is in October of last year. This is a 64-year-old African-American male who presents to the Dallas VA emergency room with pain for 1 week. He describes this as acute, severe back pain radiating to his chest, not associated with any shortness of breath or diaphoresis. Of note, yesterday he reported he did perform some yard work. His past medical history is significant for non-ischemic cardiomyopathy with a moderately depressed ejection fraction of 35%, which was assessed in 2013. He does have a biventricular automatic implantable cardioverter defibrillator or bi-VA-ICD in place, hypertension, chronic kidney disease, stage 3, and 1 pack per day smoker. His family history is notable for premature family history of coronary artery disease in his father. His current medications include aspirin 81, metoprolol XL 250 milligrams daily, amlodipine 10, a statin, and a low-dose diuretic. On presentation, he is afebrile with a heart rate of 77, mildly elevated blood pressure at 145/92, with a respiratory rate of 20, setting 94% on room air. Per ED notes, his physical exam is unremarkable. This is a prior EKG demonstrated basically normal sinus rhythm. He does have occasional PVCs, and based on his AVL lead and his R wave, he meets criteria for left ventricular hypertrophy with some mild QRS widening and some nonspecific T wave changes in the lateral leads. His current admission EKG, even though I mentioned he was not tachycardic on presentation, on this EKG you can clearly see that he has sinus tachycardia at about 120. Again, he meets criteria for left ventricular hypertrophy with QRS widening, as well as repolarization abnormalities. This is a chest X-ray. On the left-hand panel, you can see a prior chest X-ray. This current one is much more zoomed in, and as you can see, he has per radiology, possibly some left lower lobe effusion with some infiltrate. He has prior leads on the right that are not connected, as well as his current device that has leads that are connected. And then they commented here on the sort of prominent aortic knob and just called this aortic ectasia. In terms of labs, just mildly decreased potassium. Notably, he does, as I mentioned, have a history of chronic kidney disease. His creatinine on admission is 3.18 with a GFR of about 24. And this is elevated compared to 7 days prior when his creatinine was 2.25. On his cardiac enzymes, you can see that he has a mild elevation of his CKMB and notably elevated troponins at 2 and on subsequent recheck up to 8.
So we have a number of abnormal lab findings here, and I think the tendency might be to focus on the troponins, but there's a number of, I think, historical features and some lab findings that are just not, and other objective findings that are not necessarily consistent with an acute coronary syndrome. And so I'm gathering that you're going to consider other options, other causes, right?
Yes, so this is early morning. You don't have a lot of backup help. So you're trying to decide, do you, A, activate the cath lab for STEMI? Again, the EKG is not consistent with that. B, order chest CT to rule out a pulmonary embolism. C, get blood pressure measurements in all extremities to evaluate for aortic dissection. D, anticoagulate with IV heparin due to the elevated cardiac biomarkers for acute coronary syndromes. Or E, obtain a stat TEE. So again, this is sort of early morning with the different biomarkers. I highlighted different ones and different options you might be considering at that time that are not entirely unreasonable. Of note, if you are concerned for aortic dissection, pulse differences or pulse deficits are only found in about 1 in 5 patients, so it's not the most specific sign. So here are his transesophageal echocardiogram images, and I'm going to walk you through them. So on the top left-hand corner, basically this is a long axis view through the LV outflow tract here with the aortic root that is intact. On the top right panel, which is not playing, in the sort of the aortic arch, you can see here that in the lumen there is this line. And then more clearly here, you've heard a little bit earlier that X-plane is a way to take orthogonal pictures. You can see clearly that there is sort of this flap that is moving. There's some spontaneous echo contrast here, which would be consistent with a false lumen. And so this is very suspicious and concerning for an aortic dissection. For further determination, the patient underwent a CT angiogram. And on the coronal view, on the, let me forward again. On the coronal view up here, again, you can see contrast in the left ventricle into the aorta, showing an intact lumen. But as you go further down in the axial views, you can see here, you can start seeing the tear. And this is beyond the takeoff of the left subclavian artery. And then over here, the tear continues down the descending aorta with possible involvement of the mesenteric artery. And then on the bottom right panel here, you can see the true lumen is feeding the right renal artery. And over here, the false lumen, there's concerning that there's extension of this tear into the left renal artery.
So Jessica, you've shown two different imaging modalities here that have identified this dissection, and it brings the question is how do these compare, and are there other options?
Okay.
And particularly given the time of day, the availability of staffing, and things of that nature.
So here's a little bit of data in terms of diagnostic imaging accuracy for aortic dissection. There's a published meta-analysis using 16 prospective studies between the 1980 and 2005 with a total of about 1,200 patients. As you can see in the table listed the studies, here CT was found to be basically the most sensitive for ruling out the dissection at 100% versus MRI that had the highest positive likelihood ratio at 25 of basically confirming a dissection. However, the p-value was negative, and so in conclusion, the study found that all three imaging modalities were essentially clinically equal in determining whether there is a dissection or not. Of note, very important to remember that TEE can be quick to obtain, especially if the patient is hemodynamically unstable. However, it is limited in assessing the distal ascending aorta, as well as its branches due to shadowing from the trachea and the left mainstem bronchus. CT is sort of very quick to obtain and is the least operator dependent. And then finally, MRI, although it was the most specific in confirming a dissection, can be associated with time delay, and depending on which institution you work at, there may be a lack of availability to perform the study. So next, we go to on what would then be the best management for this dissection. A, medical management with blood pressure control and serial pulse checks. B, give dual antiplatelet therapy with aspirin and clopidogrel. C, consult thoracic and vascular surgery, or D, destruction with follow-up in 1 week.
You can answer that question for yourselves. But I think we'll have the answer here in just a second.
All right, so a little bit of background in terms of prognosis with aortic dissection. The mortality rate is especially high if it's a type A dissection with mortality of 1 to 1.5% per hour, so 50% mortality at 2 days or 48 hours. Malperfusion syndrome can be found in about 10% of the patients, and this is defined as basically decreased perfusion to the spinal, the iliac, or the visceral arteries. Some of the adverse predictors to keep in mind, especially if the patient has symptom recurrence, meaning persistent ongoing back pain or chest pain. If the aortic aneurysmal dilation is more than 5.5 centimeters, or if there's a yearly increase of more than 4 millimeters on serial imaging. And on a logistic regression, it was found in the study that the deadly triad was basically defined if the patient presented with hypotension or shock, and that was the worst predictor of outcome. In addition, if the patient had absence of chest or back pain, he did worse because there was much delay basically in diagnosing the dissection. And then finally, if there was branch vessel involvement, and most of the time, That can be found if the patient has paraplegia. He can have nausea, diarrhea from involvement of the visceral vessels. So in this case, the patient basically would fit in the category of a complicated dissection due to the possibility of the renal involvement with the elevated creatinine as well as the visceral vessels. In terms of management of aortic dissection, there was an expert consensus document that was published out of Western Europe. They reviewed the 63 studies on aortic dissection from 2006 to 2012 with a total of up to 7,000 patients. Of note, most of these studies were not randomized. It was found that in the acute setting, that with medical measurement, the early pooled mortality rate was about 6%, versus 10% with endovascular aortic repair, compared to the highest early pooled mortality with open surgery. As you can see, patients that were managed medically actually had a fairly good 5-year survival between 70% to 90% compared to their counterparts who underwent TEVAR surgery. In patients who presented with a subacute aortic dissection, there's more limited data, and they found about a 3% TEVAR pool mortality. And in patients who had a chronic dissection, the mortality rates were about the same between TEVAR and surgery, as well as the survival was similar, except that patients who underwent TEVAR were less likely to have freedom from reintervention over time. And so our patients underwent basically that afternoon thoracic endovascular aortic repair. And here are some images from the intervention from our vascular colleagues. On the left-hand panel here, you can see there's a catheter here in the aorta. And here you can see the stent being deployed across the top of the aortic arch covering the left subclavian artery origin. Most of these stents can be fenestrated and flow into the branch vessels to the head and neck and arms can be maintained. They also placed one stent, a self-expanding stent, into the celiac artery. And then on angiography, found that there was actually good flow to both to the right as well as the left renal artery, so no interventions was actually needed on the renals. So a few take-home points from this case. When evaluating a patient, other etiologies of chest pain need to be considered aside from acute coronary syndromes. MRI, CT, as well as TEE are clinically equally reliable for diagnosing thoracic aortic dissection. Of note, if it is an uncomplicated type B dissection, these can be managed with medical therapy as well as obviously closely followed to evaluate for complications. If the patient does present with any features of a complicated dissection, as I described earlier, then the patient would preferably be treated with a thoracic endovascular aortic repair over open surgery, which yields a lower, earlier in-hospital mortality rate. And then uncomplicated type B dissections should undergo yearly clinical imaging follow-up. And in the short term, it was actually recommended to do imaging on admission at 7 days, on discharge, and at 6 weeks, so that you can make sure that the dissection does not progress. And with that, we'll take any questions.
Jess? Hi.